Hello and welcome to Ask Your Doctor. This is an informative health session that is sponsored by My American Doctor. We are a group of highly trained and experienced doctors, and we represent all specialties and provide second opinions throughout the country. We are not here to give individual health advice or treatment plans, but we are just here to kind of offer a generalized idea of certain conditions and give you guys some more information. If you still have questions or need any further clarification, you can get in touch with us. Today, we have the pleasure of speaking with Dr. Sridhar Guduri. Hi, thanks for being here today.
Morning.
How are you doing?
Good, how are you?
Good, thank you. Well, today I'd like to understand a little bit more about allergies, asthma, atopic dermatitis, and hives, both in general and how they might affect daily life. Can we start broadly and then get into more kind of specific situations today?
Sure.
Awesome.
Morning, good afternoon, good evening, wherever you are. As Ariana said, my name is Sridhar Guduri. I'm an allergist in a single specialty group practice here in Columbus, Ohio, for more than 20 years. It's a pleasure to meet you all in this live setting. This is a first for me, so I'm as excited and looking
Awesome.
forward to chatting with you.
Yeah.
I deal with allergies, asthma, and atopic dermatitis, commonly referred to as eczema. These are the three most common conditions I deal with on a daily basis. They're different manifestations of the same underlying process, hence, that's the thread that connects all three conditions. Allergies, broadly speaking, is a result of exaggerated immune response to otherwise inert stuff like pollen. When you think about it, your body should not be reacting to pollen. It's not going to do any harm. It's not like a virus or bacteria. But it does in patients with allergies. The end result is a release of a bunch of chemicals and mediators, resulting in symptoms like runny nose, stuffy nose, sneezing, itchy, watery eyes. Asthma is the same process, but happens in the lungs, which leads to symptoms like trouble breathing, wheezing, tightness, and cough. And eczema is when skin is affected by the same inflammatory process, and that leads to rash and itching. My typical patient would be someone with a history of eczema or food allergies as a child, and then developing allergies and asthma later in life. We call this commonly the atopic march. These are very common. Asthma affects almost 8% of the US population, allergies much more than that, almost 25 to 30%. Eczema affects 15% of the kids and about 7 to 8% of adults. So we're talking tens of millions of patients.
Mm-hmm.
Why are these important? These conditions rarely are life-threatening. We rarely hear about someone dying from an acute asthma attack, but that's about it. But as for the quality of life, they make your life miserable just because of disabling symptoms, leading to work absenteeism or more often presenteeism. They're there at work, but not productive enough due to various factors, fatigue, sedation, side effects from the drugs. And also the healthcare costs can run into tens of billions of dollars every year, especially with asthma.
Mm-hmm. Yeah, I've dealt with asthma and allergies in my entire life, and it's a lot of health visits, a lot of medicine, a lot of preventative factors, and can definitely, affect the quality of life of a few people. So thank you for sharing that today. We're gonna kind of start with allergies here. So what are the most common allergies that you see in your practice?
Environmental and food allergies, we deal with both on a daily basis.
Mm-hmm.
Environmental allergies are probably more common. Most common allergies are for dust mites, which are like small insects, pet dander, cats, dogs, and rarely other small animals like rabbits, guinea pigs, and stuff. Pollen, trees, grasses, and weeds, and mold. These probably include pretty much all environmental allergens.
Mm.
Among foods, milk, egg, soy, peanut, wheat, tree nuts, and shellfish account for more than 90% of food allergens. There are other rare ones to different fruits and vegetables, but they're much, much more rare.
Mhm.
Uh, I also deal with bee sting and drug allergies, but they are much less common compared to environmental and food allergies.
Mhm. So, how can you tell the difference between an allergy and a different kind of like sensitivity or reaction?
Yeah, so I see patients coming in every day thinking they have allergies. I wish they had, but 50% of my patients don't have allergies.
Mhm.
Common illnesses that can mimic allergies, most common would be viral infections, but there are other types of rhinitis, like you can have runny nose with exposure to cold air, eating spicy foods, sometimes drugs that cause nasal congestion like beta blockers. Common symptoms are runny, stuffy nose, itchy, watery red eyes, postnasal drainage, and cough. But allergy symptoms usually don't have fever, almost always have itching.
Mhm.
They last for weeks to months, not just days. They usually have a seasonal pattern, especially if you have seasonal allergies. Unlike others, like a viral illness is usually self-limiting, lasts for 7 or 10 days. Much more common in the winter, which is exactly the opposite of allergies.
Mhm. Mhm. So, what are the current best practices for testing and diagnosing allergies that you do?
So before we talk about testing, I just want to make sure, there should be a reason to test. It's never a good idea to screen for allergies. You get a lot of false positives. But once you find the right patient with the clinical symptoms, you have two ways of testing. One is by skin testing, which is what we do on a daily basis. It involves pricking very superficial prick on the patient's skin with the allergen extract. So we have extract for, say, dust mites, cat, dog, pollen, mold. Skin testing is fast. You know the results in 15 to 20 minutes,
Mhm.
much more sensitive than blood testing. The other way to test for allergies is by blood testing. It's called immunocap testing. And we do that, not as commonly as skin testing.
Mhm.
It's expensive. It takes 2 or 3 days for the results to come back, not as sensitive.
Mhm.
But yeah, those are the two ways to test for allergies.
Okay. So that first option you mentioned, I think I've seen that before. Where it's you usually test on like someone's back
Yes.
and kind of have a bunch of different things that you test for, and then
Yeah.
whatever like raises, what is it, like a rash or something? Is that how you can tell?
Right. So when we prick the skin, we are introducing the antigen. The cat antigen, there's a dog antigen, there's a dust mite antigen.
Hmm.
Once you introduce that into the superficial layer of the skin, if the patient has allergies, that means they have an antibody called IgE in their skin, tissue, and blood.
Hmm.
Once the antigen is introduced, the IgE to that specific antigen binds to it and results in a chemical reaction, which results in the release of all the mediators. One of the major ones is histamine.
Hmm.
That causes swelling, redness, and itching.
Hmm.
So at the site of the prick, we call it a wheal and a flare reaction. Wheal means swelling and the flare means redness. And then you compare with the negative and positive controls, and that's how you diagnose allergy
Okay.
by skin test.
Hmm. Hmm. So if someone is like allergic to something, do you typically see that they are allergic their entire life, or sometimes people kind of lose that allergy throughout life?
Yeah, allergies are much more common in kids and younger adults.
Hmm.
Um, Most of the patients, I would say at least 40 to 50% of the patients do outgrow their allergies, especially with foods, say for milk, egg, soy, or wheat. These are outgrown almost more than 90%. There are a few allergies that usually kids don't outgrow. Those are peanut, tree nuts, and shellfish. They usually last for life.
Hmm.
But again, only 50% of patients are kids, 50% are adults. So there is a good chunk of patients who do not outgrow allergies.
Mm-hmm.
Saying that, I rarely see someone above 60 to 65 years of age presenting with typical allergies. So I don't want to say they're a lifetime, but they can be there for decades.
Mm-hmm. Awesome. Well, thanks for sharing that. How have treatment options changed in recent years for patients with severe food allergies?
Unfortunately, food allergy research is still in its infancy. Even today, we don't have many options. The only option that works is avoidance, strict avoidance, especially for life-threatening food allergies.
Mm-hmm.
Oral desensitization, which is like giving the food that the patient is allergic to in small amounts and increasing amounts every day or every week.
Mm-hmm.
It is offered. I don't do it. It's not widely available. It's very labor intensive, and the compliance rate is very low because the patient has to be ingesting that food for life
Mm-hmm.
on a regular basis. But it is available. Uh, it almost works like allergy shots. The other option that's been recently approved by FDA for food allergies is Xolair, which is a biologic. It's an injection that's given every 2 to 4 weeks. And that's been shown to be effective for food allergies. But again, I don't want to say that's a cure.
Mm-hmm.
What it does is increases the threshold to have a severe reaction. So for a patient who reacts even to traces of peanut, once he's on this Xolair, he or she might take 3 or 4 peanuts to have a severe reaction.
Mm-hmm.
It's good for the patient. They can't go and eat peanuts on a daily basis. But if accidental exposure happens, the risk of having a severe reaction goes down once you're on this injection.
Mm-hmm.
There is research going on with peanut allergy, but again, it's still in its infancy.
Mm-hmm. So do you typically just see patients like just kind of avoiding these things for life rather than going these routes for these kind of procedures and such?
Yes, I just started using Xolair, but I only have like 2 patients on it. But again, it's only recently been approved.
Mm-hmm.
So I can the use of Xolair food allergies going up in the
Mm-hmm.
next few months to years.
Mm-hmm. Awesome. Well, we are going to move on to asthma now, which I'm interested to hear about this because, like I said, I've dealt with asthma my entire life, so I've kind of see how it has affected my quality of life. So, how often do you see asthma being triggered by allergies, and how are the two connected?
So allergies and asthma, as you said, are connected. We call it a unified airway. If you think about it, a small particle can make its way from outside environment through the nose, through the pharynx, larynx, into the lungs. It just has to be small enough. That's why it's called unified airway. And this is how allergies and asthma are connected. Allergies account for 90% of asthma in kids, not as much in adults. About 50% of adults with asthma have allergies.
Mm-hmm.
Uh, Again, as I said before, it's the same inflammation. If the inflammation is happening in the nose and the sinuses, you have the nasal and sinus symptoms. If it happens in the eyes, you have the itchy, watery eyes. But if the same process happens in the lungs, it's asthma.
Mm-hmm.
It's been proven by the fact that treatment for asthma helps patients with allergies too, especially with the new treatments like biologics. They treat both allergies and asthma.
Mm-hmm. So they're kind of easy to get mixed up then, since they kind of feel the same, or.
The symptoms are different though. If your nasal and sinus and eyes are affected, it's the symptoms are usually runny nose and stuffy nose, itching. Asthma is more like trouble breathing, wheezing, chest tightness, cough.
Mm-hmm.
You
So
should
do
be
you
able to it's allergies or asthma just by the symptoms.
Okay, got it. Um, So what symptoms should prompt someone to seek urgent care then for asthma?
Worsening symptoms like trouble breathing, wheezing, um, not able to take a breath in or breath out,
Mm-hmm.
is not responding to medications. And in late stages, sometimes you may not hear any wheezing, but that's more because not much air is moving, and that can become a true medical emergency.
Mm-hmm.
I would say if the inhalers are not working, go seek medical attention right away.
Mm-hmm. Mm-hmm. Are there new advances in asthma treatment that patients should be aware of?
Yes, the standard treatment for asthma depends on how severe it is.
Mm-hmm.
There are rescue inhalers like albuterol, and there are maintenance inhalers, which are mostly inhaled steroids. For mild and intermittent patients, we just use albuterol as needed. They don't need to go on a maintenance inhaler. But for more moderate to severe patients, we use different kinds of inhaled steroids. And there are combos like long-acting albuterol and leukotriene antagonists like singular. But in the last few years, what has changed the treatment landscape is biologics. So there are now 6 approved for asthma. These are not steroids, so we don't need to worry about the long-term effects of steroids. They're very expensive, so usually they're not approved for mild asthma. They're only for moderate to severe asthma, but very, very effective. When I started training, we didn't have any biologics at all. All we had was steroids, either inhaled or oral steroids like prednisone. But I rarely have patients going on oral steroids on a long-term basis these days just because of these biologics.
Mm-hmm. So are these biologics, is it like a pill or a shot, an injection?
No, most of the biologics are injections. They're given every 2 to 8 weeks, depending on which one you choose.
Mm-hmm.
They can be given in a home setting. Reactions are very minimal. But again, the problem with them is the expense.
Mm. So a lot of patients aren't really choosing this route because of the price at this point right now. Is that kind
Yeah,
of
the price aspect comes more from the insurance standpoint.
mm-hmm.
It's not that easy to get these approved, but for the right patient, this can be done. Yeah.
Mm-hmm.
The data is there to show the insurance companies these work.
Mm-hmm. So at the core, what exactly do those kind of do? Do they change certain like cells or what?
Yeah. So these biologics target different steps in the inflammatory response.
Mm-hmm.
Xolair, which I mentioned before, food allergies, we use it for asthma. In fact, that's the first biologic that was approved for asthma. It binds to the allergy antibody called IgE. So now there is less IgE to drive that allergic reaction.
Mm-hmm.
And another biologic is it's called dupilumab or Dupixent. It counteracts or blocks a set of cytokines called IL-4 and IL-13.
Mm-hmm.
And the result is the same, blunting the inflammatory response.
Okay.
And so almost all biologics work. They work at different steps
Mm-hmm.
in chemicals and receptors,
Mm-hmm.
but it is the same.
So would that be something a patient would have to be on like for life then if they chose that route?
Yeah, that's a good question. Yeah, the easy answer is we don't know,
Okay.
at least yet. But what I do is start them off as per the clinical indication every 2 or 4 weeks. Sometimes if the patient is doing really well, I try to extend it. Like, for example, if Xolair is given once a month, I try to go every 6 weeks or 8 weeks and see how they respond. But stopping the biologic completely, we haven't been that successful. I can remember quite a few patients who come back in a few months or a couple of years saying the asthma is getting worse.
Mm-hmm.
For now, the easy answer is we don't know how
Mhm.
long we continue these biologics.
Yeah. Awesome. Um, and last question here in the asthma category. How can patients best prepare themselves or their children for dealing with asthma flare-ups?
Yeah, so be compliant with the maintenance medication, which you are supposed to take every day. Be aware of the right technique because asthma inhalers come in different forms. It's not that easy to figure out the technique, but once you figure it out, it becomes a habit. If you're taking the medication but using the wrong technique, you might as well not be taking the medication.
Mm.
Triggers, avoid as much as possible, like allergens. Peak flow monitoring. This is like you can think of it like blood glucose monitoring for diabetes. You can do this simple step at home. Actually, it's a small device where you forcefully blow out into the device, and it will give you a number
Mhm.
depending on age and height and weight. And lower the number, that means something is going wrong. Maybe an impending asthma attack. So it helps you in monitoring asthma on a daily basis at home. And start your rescue medicine sooner rather than later, and seek medical attention if they're not working.
Mhm. Mhm. Yeah, I remember going to like my asthma doctor when I was younger, and they would do this kind of test like that where I would blow into a machine and then like try to blow out candles or something like that. And I think that would test my strength then of my lungs. Is that what it is?
So you're talking about spirometry, and we do that in office every
Mm-hmm.
day. Uh, you can think of peak flow metering at home as a very crude way of doing a spirometry. Spirometry gives you a little more information than just peak flow.
Okay, got it. Yeah. All right, and let's move on to a topic, dermatitis, more well known as eczema. What are some of the biggest misunderstandings that you see about eczema?
Not all rash is eczema. First thing I want to say.
Mm-hmm.
Eczema definition is a rash that itches. That's it. That's the definition of eczema.
Mm-hmm.
Not all eczema is allergy eczema. It is characterized by dry, scaly red patches, usually involving the face, trunk, in front of the elbows and behind the knees. Much, much more common in kids compared to adults. Just because you have eczema doesn't mean it's allergies. It could be contact dermatitis, it could be stasis dermatitis, it could be neurodermatitis. So there are different types of eczema,
Mm-hmm.
but I will say allergic eczema is probably the most common.
Mm-hmm.
Different reasons why someone develops eczema. Genetics play a role, environment plays a role. As for the genetics, there is a mutation that's seen in almost 50% of the patients. It's called a filaggrin mutation. You can commercially test for it, actually.
Mm-hmm.
Environmental factors, allergies, of course, both foods and environmental allergens. Irritants, physical factors like cold, heat, sweating, all of these can worsen eczema.
Mm-hmm. So someone who has that kind of like mutated gene, but they find it harder than to find that relief than if someone who dealt with eczema because of like environmental factors.
Because you can't change your genes, right? So this filaggrin, it's like a glue for the skin cells. It keeps the skin barrier intact.
Mm-hmm.
With mutation, there is not much filaggrin in the system. So it leads to the breakdown of skin barrier. And then what happens? It leads to easier penetration of all the allergens and irritants into the skin. There's no way to correct the mutation, but yeah, it is. The prognosis is not as good in the patients who are positive for this mutation.
Mm-hmm. So with patients like that, would you provide like a kind of steroid cream, something more topical for them, or would they take something internally?
So the standard treatment for eczema is, again, it depends on how severe the eczema is. Uh, First thing is moisturization.
Mm-hmm.
I would say very, very aggressive moisturization. We have creams, we have ointments, we have lotions. I'm not usually a fan of lotions when it comes to moisture.
Mm-hmm.
You can tell is if you can pump it, it's a lotion. It's water-based. I
Mm-hmm.
generally recommend don't use anything that you can pump. Use something like oil-based, which comes in a jar, and you can just apply with your fingers.
Mm-hmm.
Ointments are more thicker than creams. Some patients don't like that.
Mm-hmm.
Make sure the moisturizer is fragrance-free. One of my favorite brands are CeraVe and Vanicream.
Mm-hmm.
There are emollients which soften the skin, like Vaseline, petroleum jelly, mineral oil, lanolin, but humectants. But we don't usually use it in eczema because they can be very irritating for the patient because of how thick they are.
Mm-hmm. And what
If
would
the,
an example?
sorry,
Sorry, you said humectant. Is that what you mentioned?
or
What
like
would be an example of that?
urea, lanolin, but
Okay.
they're used for more severe conditions like psoriasis or ichthyosis.
Okay.
I prescribe them to my patients actually.
Mm-hmm.
So if moisturizing is not working, then you go to therapeutic option, topical steroids. Now we have quite a few non-steroidal topical therapies and oral and injectable therapies for moderate to severe eczema, just like asthma.
Mm-hmm.
First choice is, of course, topical steroid, but the problem is you cannot use them in sensitive areas
Mm-hmm.
like face, skin folds, areas with thin skin like eyelids,
Mm-hmm.
and have side effects, thinning of the skin telangiectasias, and the
Mm-hmm.
systemic if you use high potency steroids long enough. Recently, there's been a lot of research into eczema, and quite a few medications have been approved. These are called JAK inhibitors, Janus kinase inhibitors. As of today, we have three approved. One is oral and two are topical. They can be considered as biologics also. They target a signaling pathway called JAK-STAT pathway, and result is suppressing the immune system basically.
Mm-hmm.
But the downside with that is side effect is immune suppression. So we need to keep an eye on infections.
Mm-hmm.
And there are biologics, just like we use for asthma. There's few of them are approved for eczema also. There are 4 approved right now. These are all injectables.
Mm-hmm.
Pixent is one of them actually, which has been approved for asthma for a long time.
Mm-hmm.
And there are 3 other biologics. So yeah, there are quite a few non-steroidal options for eczema these days.
Mm-hmm. Mm-hmm. Just a curious question then. So biologics, is that kind of like where medicine is moving? Is that kind of where you're seeing kind of more, treatment plans are coming in that form?
Yeah, biologics are actually they're derived from monoclonal antibodies. They're basically made in the lab from
Mm-hmm.
single cells. They bind to certain targets like the antigens or their receptors, and thus block that inflammatory reaction.
Mm-hmm.
Um, End result of all those cytokines being released is blocked.
Mm-hmm. Mm-hmm. Got it. Um, how do you usually approach treatments for mild cases of eczema versus severe cases?
So mild eczema is again moisture, moisture, moisture.
Mm-hmm.
There is no shortcut for that. I usually tell patients your skin should look almost slippery. That's how moist it needs to be.
Mm-hmm.
The best time to apply it is right after the shower, and then as many times as possible over the day.
Mm-hmm.
Uh, this is especially true in the winter time when the environment is already dry and less humid. Winter is usually the worst time for patients with eczema. If the moisturizing is not working, then you go to treatment options. I
Mm-hmm.
mentioned.
Mm-hmm. And what roles do factors like diet or stress potentially play in eczema?
Yeah, food allergies are associated with eczema, especially in kids.
Mm-hmm.
About I would say less than half, 30 to 40% of kids with eczema have food allergies. Most common are cow milk, hen's egg, wheat, peanut, soy, and fish. I don't want to say it's a cause and effect. There's no proof to say food allergies cause eczema, so it's more of an association. And elimination of those foods does improve asthma in those kids.
Okay.
We think it's because of compromised skin barrier that they develop these food allergies.
Mm-hmm.
So it's not a cause and effect relationship.
Mm-hmm.
And there are
So,
other factors like stress,
mm-hmm.
especially in adults, and that has something to do with cortisol release, which leads to immune suppression in the short term, but in the long term, it leads to pro-inflammatory response, and stress thus leads to worsening of eczema. And the other thing we notice is itch scratch cycle. It's almost like their brain is telling them, skin is itching and go scratch. It becomes a catch-22. You itch, you scratch, and just because you're scratching makes you itch more, and then it becomes a cycle.
Yeah. Mm-hmm.
Break that cycle. As long as you don't break the cycle, eczema is not going to be well controlled.
Mm-hmm. So you have to like tell yourself, like, don't scratch, just apply lotion or something.
That's one. And again, this is where I come back to the moisture. Moist skin doesn't itch as bad as dry skin.
Mm-hmm. Yeah. Do you oftentimes recommend to your patients to kind of look at their dietary kind of factors when dealing with eczema? Do you usually tell them to kind of
Yeah,
fix that?
I do that especially in kids. In fact, we even test for some common food allergies in patients coming with eczema. Not all of them. And this is much more rare in adults. And usually the adults will complain, okay, I eat this and then I see worsening of itching or rash. When
Mm-hmm.
that is there, then I go and test. But usually I don't screen for all kinds of food allergies in patients, in adult patients coming with eczema.
Mm-hmm. Mm-hmm. All right, thank you for that. We are going to move on to hives. What tends to cause hives in most patients that you see?
I wish I had a good answer for that. Easy answer is
Yeah.
we see hives pretty much every day.
Okay.
They can be acute or chronic. It's just an arbitrary definition. If it's less than 6 weeks, it's acute. It's more than 6 weeks, it's chronic.
Mm-hmm.
The reason they divide them into two is acute usually is self-limiting. They're usually because of your body's trying to fight off a viral infection, or you have an allergy to some food or drug reaction, insect bite, physical triggers like heat, cold, sometimes can cause hives too. But as long as it's less than 6 weeks, the chances are it's going to go away and not come back.
Mm-hmm.
Once it turns into chronic, that's where we see most of these patients in the clinic. There's a condition called chronic idiopathic urticaria. What it means is basically you have chronic hives, we don't know the reason why. This constitutes about almost more than 90% of the patients who come in with hives for more than 6 weeks. There is a small subset of patients, mostly females. We do see autoimmune urticaria.
Mm-hmm.
Associated with other autoimmune diseases like lupus and rheumatoid arthritis. In fact, there is a blood test to confirm this diagnosis. It's called chronic urticaria index test. Again, we think it's autoimmune etiology, so responds well to immune suppressives like cyclosporin, but again, this is a very rare condition actually.
Mm-hmm. When should someone worry that their hives might be a part of something more serious?
When the hives are associated with other symptoms like tongue or throat swelling, trouble breathing, wheezing, feeling like you're going to pass out. So now we're talking about angioedema and anaphylaxis. That needs immediate medical attention. When the hives are associated with other constitutional symptoms like fever and joint pains, hives lasting for more than 24 hours, or when the hives are healing they're not completely gone, but they leave some scarring or darkish discoloration. There's a condition called urticarial vasculitis. Then we need to worry about other systemic conditions like autoimmune diseases or vasculitis. That may need dermatological or rheumatology evaluation.
So what are hives exactly? Are they like blisters on the skin?
Yeah, so hives are also commonly referred to as welts. So they're red, itchy, very itchy, red, kind of bumpy, but very discreet. They can be very irregularly shaped, but they're it's not rash. Hives is not rash. Two different things. And the most important thing with hives is they come and go. If you have a hive, say, on your arm, it won't last for more than a few hours. It's gone. It's completely gone. Skin looks completely normal. So they're very transient, unlike rashes. Rashes can last for days. Hives, not so. Usually from the history, you can tell whether are we dealing with hives or rashes.
That makes sense. So there are chronic forms of hives, like we kind of talked about before. How are those then treated differently from just kind of the ones that pop up and are gone in a few hours?
If you have acute hives, you just take a Benadryl or some kind of a nonsense histamine like a Zyrtec or Allegra, and they go in, and that's it, you're done. But with chronic hives, these patients are having hives on a regular basis. So just using antihistamines as needed is not going to cut it. They will need oral antihistamines, which is the first choice on a regular basis. Sometimes once a day dosing works, but I go up as much as 4 times the regular dose if needed. And if that's not working, then we go to the next steps, which is I use a second antihistamine or use something called Montelukast acid, which is singular. And now we have Xolair, which probably is working the best for chronic hives. And the biology that we talked about before. That for hives much better than any other medication for chronic hives. And that's an injection every 4 weeks. Rarely I use a cyclosporin, more in autoimmune urticaria. I don't use methotrexate anymore, because of side effects. There is another biologic that was just recently approved in the last few weeks, Dupixent, but I haven't used it yet for the chronic hives.
Okay. Yeah, I've seen some commercials for that one, I think. It seems like a lot of these kind of treatment plans are similar then for a lot of these conditions that we've talked about here. So someone that's maybe dealing with a lot of these, they would see relief in maybe taking one of those kind of treatment plans, and then maybe all of their symptoms would go away.
The reason for that is the underlying process is the allergic inflammation. It's the same chemical mediators. Patients, some of these biologics are like 2 birds with 1 stone. You can treat asthma and eczema with Dupixent. It's approved for both. You can treat asthma and hives with Xolair.
Yeah. And then last question here for the hive section. What emergency steps should someone take if they develop hives along with the swelling in the mouth or throat? Is that when you go to the kind of ER then at that point?
So now you're talking about angioedema or anaphylaxis. Anaphylaxis for sure, it needs, you need your epinephrine, and then you need to be seen in the emergency room. Angioedema, which is like hives, it just the process happens deeper in the skin or in the mucus. That depends on whether it's severe or not. If your throat is closing up, yeah, you need to go to the emergency room. If I feel my patients are at risk for developing this, I usually prescribe epinephrine or EpiPen in common part. It's an injection that's kept for immediate use. It's very easy to administer. That's the drug of choice for treating anaphylaxis. It can be a lifesaver. Sometimes seeking medical attention can take some time when you're developing an acute reaction.
Mm-hmm.
that EpiPen comes in. Sooner the better.
Mm-hmm.
If if you're thinking, should I take EpiPen or not, take it. That's what I always. If you take EpiPen when you don't need it, it's okay. The half-life is less than 5 minutes. The side effects are going to go away.
Mm-hmm.
The problem is if you need it and if you don't take it, that can be life.
Mm-hmm.
Yeah, treatment for an acute allergic reaction is EpiPen, EpiPen, and EpiPen. And then, of course, go to the emergency room.
Mm-hmm.
And they might need supportive treatment like antihistamines, oxygen, and fluids. I will say this, the reason for going to the emergency room after you use EpiPen, even if your symptoms are resolved, is because there is a late phase anaphylaxis that happens in about 20% of the patients. It can happen 2 to 6 months later. That's the reason why I always tell patients, if you use EpiPen at home, go to the emergency room no matter what.
Mm-hmm.
And they might need a short course of steroids to avoid that late phase reaction.
Okay, that makes sense. Yeah. Do you sometimes see like patients who have eaten something they're like allergic to? Do they develop hives? Is that kind of like a side effect of some allergic reaction?
Absolutely, yeah. So an allergy depends on how severe it is. It can be as mild as a few hives and then everything is gone.
Mm-hmm.
For that, you can just take an oral antihistamine. But it can be as severe as throat completely closing up, low blood pressure, passing out, trouble breathing, wheezing. That's the anaphylaxis we're talking.
Mm-hmm. Mm-hmm.
Allergic reaction, it's a spectrum from very mild to the most severe, resulting in death.
Mm-hmm. Awesome. All right, we're going to move on to some patient advice and prevention. What general advice do you give for preventing flare-ups or acute episodes of these conditions?
It depends on the condition. So now you're talking about mostly asthma. That's probably the most common condition in our practice that causes acute flare-ups. As I said before, be compliant with medications and make sure you're taking it the right way. Avoid the triggers as much as you can. Uh, your peak flows, dropping numbers is not a good sign.
Mm.
Identify the acute symptoms. Use your rescue inhalers sooner rather than later, and seek help sooner rather than later.
Mm-hmm. Yeah. So like if you've been prescribed a medicine, take it even if you're not having symptoms. Just kind of stay
Yeah,
on top of everything. Mm-hmm.
that's called a maintenance therapy for asthma, inhaled steroids.
Mm-hmm.
This is a lot of patients think, oh, I'm doing fine, I don't need to take anything. But the
Yeah.
maintenance inhalers do not work like that. They are not rescue inhalers. To control the underlying inflammation, these maintenance inhalers need to be taken every day, no matter what.
Mm-hmm.
The rescue inhalers like albuterol can be used as needed. If you don't have any symptoms, you don't have to take it.
Mm-hmm. And are there any warning signs that should prompt a visit to the ER versus waiting to just go see a specialist?
Again, the same symptoms.
Mm-hmm.
If you just have angioedema or anaphylaxis,
Mm-hmm.
it's a medical emergency. It cannot wait for a specialist.
Mm-hmm.
I use that antihistamines or EpiPen and go to the emergency room.
Mm-hmm.
When do you see a specialist? This is probably decided by your primary care physician.
Mm-hmm.
You do see patients coming in just by word of mouth when the medicines are not working. Your regular over-the-counter medicines are not working, then that's a reason to see the specialist. You want to know what you're allergic to. That's a reason. And kids with eczema, do they have any food allergies? That's a reason to see a specialist.
Mm-hmm. Awesome. And what resources or support networks do you recommend for patients and their families dealing with any of these conditions here?
Yeah, at least here in the US, we have two big allergy societies. One is American Academy of Allergy, Asthma, and Immunology, and American College of Asthma, Allergy, and Immunology. Those have a lot of patient resources about allergies and asthma. There's one for food allergies. It's foodallergy.org. Excellent website for patient advocates. And there's one nationaleczema.org for eczema patients. Again, one of the best for eczema resources.
Mhm. All right, thank you for sharing those resources. Last question here. What is one thing that you wish more people knew about managing these conditions?
Um, Allergies are not always allergies.
Mhm.
I think it's allergies, but more often than not, and again, as I said before, it's 50% of the patients don't have allergies.
Mhm.
Be aware of side effects of medications, especially the over-the-counter ones, mostly sedation. So don't drive after taking your allergy medicines, especially the sedatives like Benadryl. Educate yourself, ask questions, and seek help sooner than later. And don't be afraid to ask questions with your doctor.
Mhm.
They're there for you.
Mhm. Awesome. Well, thank you for this conversation today. Appreciate all the topics. We do encourage the audience to check out our website, myamericandoctor.com, or to call us at 919-914-941-494 if you want to book a second opinion consultations or have any other questions. But thank you so much, Doctor, for being here today. We appreciate the conversation and thank you. Have a wonderful day.
Sorry, you too.
Thank you. Bye.
Bye.